Welcome to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for August 4th, 2022. Today's CME activity code is 486227. We have got a great case today by Dr. Whittier. A little different disease presentation. It'll be fun to go through the differential diagnosis. This is being recorded and it will be uploaded to YouTube, our YouTube channel by Dr. Baxi, our technical consultant, doctor, nephrologist, and person we go to with all things Epic and iPhone related. Please subscribe to our YouTube channel if you're not, and if you're not on our emailing list for our conferences, let us know. Throw us a note in the chat or send one of us an email and we'll include you. Everyone's muted except the faculty. If you have any questions, put it in the chat box. We'll try to address them as they come along. We have nothing to disclose. And to ensure patient privacy is preserved, identifying information, including gender, ethnicity, dates, exact laboratory values, and other details have been changed to disguise the identity of the patient and protect the patient confidentiality. Dr. Whittier is going to read the protocol, and then we are going to have a quick poll before we talk about the case. Bill, you want to take over?
Sorry, hold on a second. My fault. There we go. Sorry. All right. So we have a 65-year-old Black woman who we initially saw for acute kidney injury with hypercalcemia. So she initially presented to an outside hospital apart from Rush with complaints of abdominal pain, a maculopapular rash all over her chest, abdomen, and hands, and mental status changes. On admission there, she had a creatinine of 3.4, and a couple months ago it was 1.2, and her calcium was over 14. So at that outside hospital, she had received Zometa and IV fluids, and her creatinine had improved down to 2.1. Her calcium had actually improved or decreased down to 8.7. Workup at that hospital included urinalysis, which had trace protein, no blood. There was pyuria. She had a urine PC of 1.5 grams and a urine AC of 106 milligrams. Her symptoms of abdominal pain had resolved, her mental status changes had improved, and she was sent to Rush because she had some prior care at Rush. And so her prior care was mostly significant for her stage 4 follicular lymphoma. She also has a history of sarcoidosis, diabetes, and hypertension. So her lymphoma was diagnosed 7 years ago, and she had chemo, which is listed there. She had bendamustine, rituximab, and then she had an allergic reaction to rituximab, so they gave her obinutuzumab. Yeah, I'm not going to say that again, but you can get it there. It's obinutuzumab. And then she had R-CHOP with a complete remission. So she did well with that for 4 years, but then she relapsed, but again had a repeat remission induced by the drugs that you see there. And and then she had a year of rituximab maintenance for 1 year, and then the last 2 years she's been in remission. Her past medical history also was significant for sarcoid, and that actually predated her lymphoma diagnosis. And it was diagnosed by skin biopsy prior to her lymphoma diagnosis, and it had only been treated with topical steroid creams. So her past medical history is there with the lymphoma, the sarcoid, diabetes. Medication, she was on aspirin, metformin, Norvasc, Coreg, and Protonix. No significant family or social history on exam. The only thing that was really remarkable by the time we met her, which was again after her mental status had improved, was that she had this sort of resolving, darker pigmented maculopapular rash, which was on her abdomen, upper extremities, and palms of hands. There were pictures of it, but they weren't that impressive because I think it was already resolving. But there wasn't really that much else that was significant on exam. And her lab showed that her sodium was 137, potassium at 3.4, her chloride was 115, and bicarb was 18. Her creatinine, it was at 3.4 at the outside hospital on admission when her calcium was up to 14. But when we met her, she was already down to 2 with the creatinine. Creatinine was 2 and her calcium was less than 9. Total protein was 6.2, albumin 3.7, and her LFTs were unremarkable. Her CBC shows a white count of 3.3, and that was a normal differential. Her hemoglobin was 7.8, platelets of 140. Her MCV was 99. We had quite a bit of workup from the outside hospital, which was nice. Usually we're getting a biopsy right away and we have a lot of workup pending, but we had our PTH back, which was 8, the workup for the hypercalcemia. Her PTH related peptide was 1.6, also normal. Her ACE level was 56, which was normal. And her 125 dihydroxyvitamin D was also within the reference range at 69. Her autoimmune workup was negative. Her infectious workup was negative. She was noted to have a serum, monoclonal IgG lambda on serum and urine immunofixation, and her kappa lambda ratio was 0.29. Her urinalysis shows that her urine pH was 5, the protein was 1+, glucose was trace, her blood was negative, and she had 115 white cells. Her urine culture was negative. Her urine PC was 1.5, and her urine AC was 0.106 grams per gram. Her ultrasound was essentially normal with the exception of the increased echogenicity. The left kidney was 12 and the right kidney was 11. And her skin biopsy from the outside hospitals showed that there were histiocytes and granulomatous infiltration with multinucleated giant cells, consistent with those 3 diagnoses there, either granulomatous drug reaction, an interstitial granulomatous dermatitis, or granuloma annulare. And there was no evidence in the skin of lymphoma or infection.
So Bill, do you, when she had glucose in her urine, was that the serum glucose of 185?
It was tough because her glucose did range during the day. Most of the time her glucoses were less than 150 on her acute checks, but the chemistry sent to the lab that morning of the urinalysis was 185.
And do we have a serum phosphorus by chance?
I can find that out for you.
Okay. You don't remember it being low though. I think you would have.
Yes, I don't remember that being low.
Yeah, it would have been. I think you would have put it in there if it were low, but.
I'm going to go look that up now.
Any other questions? All right, before we discuss it, we're going to have a poll. Please, everyone vote. It's totally anonymous. We have 4 options that we decided were reasonable. What is your diagnosis? Single choice. Acute interstitial nephritis, acute interstitial nephritis with non-caseating granulomas, ATN from hypercalcemia, or lymphomatous infiltration of the kidney. We just got done with the ASN's board review course, and we put up a lot of audience response questions. They're a lot of fun, and I have always said the best question is when you have lots of options, not lots of options, but people pick all the options.
Perfectly.
So far,
what did the clinicians think about the lambda monoclonal IgG in the serum? The reason I ask is that that's a little bit out of the expected range for sarcoidosis. Certainly might have occurred with a lymphoma, and it raises the question of amyloid, even though the proteinuria was not great. And I'm not strongly suggesting amyloid, but that stands out as a rather unusual feature in this case.
And it also was the serum and urine immunofixation were also performed in the past, and they were negative at that time when she had the complete workup for her lymphoma in the past. So they were negative, and now they are positive as far as more clinical histories.
they didn't put much weight on the ratio, though, is what I guess Dr. Glassick's saying.
Well, remember, it is a lambda, and the ratio is low.
Yeah, I think that's his point. Yeah.
Were there free light chains in the urine immunofixation, or was just the monoclonal protein?
There in the urine, it was just the monoclonal protein.
All right, so poll ended. We've got about 10% said pure AIN, 50% the winner is AIN with non-caseating granulomas, I guess pointing towards the sarcoid. The third is ATN from hypercalcemia at 10%, and the fourth is about a third said lymphomatous infiltration of the kidney, causing this clinical presentation. Steve, which of these or whatever else you want to add to this? What do you think's going on?
Still trying to get my head around it all. There's a lot of stuff going on here. I mean, the hypercalcemia that high, I mean, sarcoid, for sure, you worry about malignancy when you see it that high. And definitely hypercalcemia can cause a diabetes insipidus nephrogenic DI, which, and it can also cause afferent vasoconstriction, which could ultimately lead to a acute ischemic injury. I mean, we see this, acute kidney injury in patients with myeloma because of the hypercalcemia. And once you correct that, the renal function goes back to normal. So, I mean, that by itself is disconcerting. And yes, it could be due to the sarcoid. Interestingly enough, the ACE level is normal and the 125 vitamin D level is normal. And so you would expect the 125 vitamin D level to be high if we're thinking that some granulomatous disorder is causing her hypercalcemia. And it's not only isolated to sarcoid. People that are that do subcutaneous injections and get granulomas. I think Jesse Haino from Loyola had a case report years ago of a patient that got hypercalcemic from sub-Q injections of some drug, and they had granulomas, and they make 1-alpha hydroxylase, which increases the 125 vitamin D and causes hypercalcemia. But that's, again, that's kind of out of the, that's negative. I mean, could there still be some sort of acute and chronic interstitial disease from non-caseating granulomatous sarcoid? I guess that's possible. That could be associated with tubular proteinuria, which would explain why the albumin is normal and the urine protein creatinine ratio is up. And if you were to look for beta-2 microglobulin, you might find an increased excretion of that. I just find it, I think it's going to be a little bit of a stretch to be sarcoid. Parathyroid hormone and the PTH related proteins are negative, so it's not due to that. It gets back to with the IgG lambda and this lymphoma, it kind of keeps coming back to that whole thing. And I'm assuming, the rash too, you could worry about sarcoid. They can get all kinds of rashes, but again, the ACE level and the vitamin D level just don't seem to go along with that. One thing they look for in these various biopsies in sarcoid patients is something called asteroid bodies, which are thought to be kind of as specific for sarcoid as hematoxylin bodies are for lupus. And I'm assuming if they would have seen that, they would have reported it. So I think sarcoid has to be lower down on the list for all of the reasons I've tried to elicit. The hemoglobin being low, there's clearly some sort of malignancy brewing here. And I think, with some sort of invasive lymphomatous process, and I'm not as aware, I have to go back, as if lymphomas per se, like myeloma, if they make like an osteoclastic activating factor, which will cause hypercalcemia, that'd be one nice way to put this together, and then have lymphoma invading the kidney as well, and the hypercalcemia, again, being a factor in acute renal failure for the reasons I've already listed. Dick brought up the issue of amyloid, and that definitely comes into play whenever you see an elevated lambda. But I would have expected there to be more albuminuria, and there's just not. The albumin is completely normal. I think Roger was trying to get to the point of maybe a Fanconi syndrome here. The glucose was only trace positive in the urine despite a serum glucose of 200. I would have thought there'd be more if there was Fanconi's. There is a low bicarb without an anion gap. I was trying to calculate it out. It's not a negative anion gap, which we would see in somebody with a paraproteinemia, but the anion gap is kind of low. It's 4. Anyway, I think we need a biopsy ultimately, and and I, where am I going to put my money? I think it's going to be lymphomatous infiltration or a paraprotein associated renal disease, whether it's Cas nephropathy, which can give you giant cells reacting around the tubules, as well as inflammation, which might account for the white blood cells, which would be another possibility. But that's kind of going off the reservation and saying there's some other issue here, like myeloma, as opposed to just the lymphoma that we know she has. So I guess to stay on course here, I think she's going to have some lymphomatous infiltration, and this lymphoma is producing a paraprotein. I don't think she's got amyloid at this point. If she did, I know I keep babbling on here as things come to my mind, I would expect it to be all interstitial and not glomerular.
Well, she does have an interstitial pattern. She's got pyuria. She's got proteinuria that's not albuminuria. And for those in the audience, Dr. Corbett brought up something, a fractional excretion of beta-2 microglobulin, which is something we used to do. We'd see, what percent of filtered beta-2 microglobulin is being reabsorbed, just like a fractional excretion of anything else. And since it's a small molecular weight protein and is reabsorbed by the tubules, it will go up if you've got tubular disease. Lately we've kind of replaced that with our albumin to creatinine ratio and a protein creatinine ratio. Normal being the albumin creatinine ratio on the same specimen should be about 60%. And here it's, quite low. It's a very low percentage of her total proteinuria is albuminuria. It's basically saying the same thing that Dr. Corbett was saying. Steve, do you not use that ACR PCR relationship, or do you still try to get a beta-2?
I do it. I do it. I still do the beta-2 once in a while. Sometimes it's more effort than it's worth, but I do urine albumin, urine protein, as you're suggesting. And the other thing to throw out there, and the person doesn't have it, they used to talk about this all the time. Myelomonocytic leukemias could cause a lysozymuria, which would cause an increase in total protein in the urine. So it doesn't have to be beta-2 microglobulin. I don't know that I've ever seen it, but I just remembered ever since taking the boards in medicine, God, 40 years ago, that would be discussed. And again, I don't know that I would ever see it. And I guess if you did a beta-2 fractional excretion on that, it'd probably be normal, but I don't know that I've ever tried to measure lysozyme in the urine, and this person doesn't have myelomonocytic leukemia.
Yeah, that's classic overflow proteinuria that's not light chains. And, just getting done with the board review course, I always say that's right for board review, for board question. But yeah, I've only seen it once in a case report at AJKD in the last year or so. It's pretty rare, but obviously worth bringing up. So your number one is lymphoma in the kidney.
I think that's what I said.
Yep.
I have to remember myself now.
I'll remind you if you ever need any help. Yes, Dick, go ahead. What do you think's going on?
Yeah, I'm very much with Steve on this case, and I would like to point out a few minor clues that can't be ignored: the leukopenia, anemia, and macrocytosis, all of which could point to a bone marrow involvement. And if there is lymphomatous involvement of the bone marrow, that would increase the likelihood of renal involvement with a lymphoma. And I would certainly downgrade the sarcoidosis notion because of the normal 125 hydroxy D. As you know, a lot of patients with sarcoid don't have an elevated ACE value, so the meaning of a negative ACE isn't all that great in terms of differential diagnosis.
Yeah, I mean, I think it's a tough one here because you've got a PPI, you've got rash, but you got more than that. You've got this hypercalcemia and this history. And I mean, anybody, this sick, I suppose, could be anemic. That wouldn't surprise me. Whatever's going on isn't good and be anemia. But yeah, it's a good point. Pravir, you have any thoughts on this?
No, I think it definitely seems to be an interstitial pattern, and you just said the protonics. That's kind of what I was looking at too, and I do think that the monoclonal does kind of worry me a little, and as Dr. Corbett and Dr. Glassick mentioned in terms of bone marrow involvement, I think that's definitely a concern. But just to be, if it's not related to that, I mean, this could easily be an interstitial nephritis. Her creatinine was 1.2 3 months ago. And now it's up to 3.4. She's on protonics. She has, non-albumin, predominantly non-albumin proteinuria. She has pyuria, assuming negative, urine culture. Don't have any evidence of, infection. So it looks like steropyuria, and this could be that. Of course, sarcoid can also cause predominantly interstitial involvement, but the markers for sarcoid in this patient at least make that less likely, and it could be that. On top of that, she has diabetes, but this is not just progressive disease, and I think this is too quick. When we see the diabetes and hypertension, chronic kidney disease, and sure, there may be some background diabetic and diabetic changes, but this acute rise with all the other markers point towards a bone marrow, or the monoclonal remains one, but if that's not it, the number two would just be I think on that poll would just be AIN, and I would blame the protonics on that.
Yeah, I think a lot of people are coming back to the calcium as what kind of throwing it, what really bothers people. Otherwise, to me, this would be protonics.
Yeah, well, you get a calcium of that high. I mean, 14.
No,
it's
because
like malignancy. Yeah.
Yeah, no, I agree. Yeah. I mean, it's the calcium that we have to keep coming back to and try to putting it together somehow.
The other thing, just as a side, those kidneys are pretty good size. 12
Yeah,
centimeter kidney, 11 centimeter.
I was just going to argue the opposite, that I would have thought, they'd be bigger if there was lymphomatous infiltration.
You get to the age of 65, things kind of peak at 40 and then they start to go down after that. I mean, you would think somewhere around a 10, 11 centimeter kidney, you got 12 centimeter left kidney, almost 12 centimeter right kidney. That's a pretty good sized kidney. Now you can get that in any kind of inflammatory process in the kidney where there might be edema. It doesn't mean it's always infiltration. As Prabir brought up, diabetes could do it too. Amyloid could do it. Again, inflammation in the kidney itself could do it.
And she is tiny. So, she's only 113 pounds and 5'5". So that might be even really big for her.
That's a good point. Steve, I'm 65. I haven't hit my peak yet. So.
Well, I had mine checked the other day and they're fine.
Okay.
They're not 12 centimeters.
I mean, you had your weekly renal ultrasound?
Just my weekly renal ultrasound. I had Bill do it with that, with that portable thing.
Yeah, the POCUS.
With that portable thing. It's called POCUS. Okay. I think before it deteriorates more, we should spin the wheel.
Especially if everything peaks at 65 and then goes downhill. I think we're all, and we better spin.
Well, I'm a few years older than you.
All right, Wheel, who's going to read this? Melanie. Second year fellow Melanie.
Give me a second here, Melanie. Spotlight. All right.
Affectionately known as Mel.
There we go. Melanie, you should be able to unmute yourself, and then I will let me share the screen. I'll let you take over.
Can you hear me?
Yep.
Perfect.
Go ahead and click on the screen. Yep, you're controlling the screen, so you should see those arrows on the bottom.
Yep.
Remember, there's a lag. Yep.
Oh, just close this chat.
Good.
We'll skip past the great faculty discussion. And okay. Okay, so we had the
Too fast. Here, I'm going to go back for you. Okay, give me a second. There we go.
Are you going to go back to the trichrome?
This is the first slide, Mel. Go ahead.
yeah, our connection is not very good, so I think it's just
lagging. Just give it a second. I can see your mouse.
Okay, so
moving.
here I see 3 cores, and here we're looking at the biopsy with the trichrome stain, looking for areas of increased uptake of the bluish material. Maybe some here around that looks like around the blood vessel. In this area, if you can see my cursor up in the top core, the tubules don't appear to be back to back, so there seems to be some more bluish uptake material with AIN on the differential. It's hard to say whether or not this is fibrosis or just like edema from inflammation, which we'll see at higher power. Looking further down below, again, the tubules aren't back to back.
Yeah. So there does end up being some patchy fibrosis here. There's a mixture of edema and we already saw the infiltrates. So I estimate about 40–50% of the kidney was scarred with fibrosis.
Okay.
Yeah.
And let's see here.
If needed,
What's
I can
next?
advance the slides. Okay, go. Yeah, perfect. Can you see that, Mel?
I can see this one.
All right, all right.
So this is the H&E stain again, looking at two cores. Looking at this section here, it's mostly looking at the tubules, and in the interstitium, I do see it does appear hypercellular. And looking up here, I can see like one glomerulus. At this power so far, it looks normal, but we'll see it at higher power. And up here,
Yeah, and the infiltrates, are they focal or pretty much diffuse throughout both cores?
looks pretty diffuse to me.
Yeah. Yep. Yeah, that was the point of this low power. There was diffuse infiltrates involving both needle cores. And then here we have a higher power of the infiltrate.
I think it's just still lagging for me.
Okay.
Okay, here we go. Yep, I see the higher power H&E stain here again. Looking at the interstitium again, I agree. It's diffuse hypercellularity. Trying to see if I can make out this what I think the cell types are at least.
So I don't know if does it look like one cell type or a mixture of cell types? Because that's important.
I think I see a mixture of cell types.
That's good. Yeah. There's no evidence of lymphoma. I can make out some neutrophils, some lymphocytes, an occasional eosinophil. How about a granuloma? Do you see a granuloma? That was in the differential.
Is this up here granuloma?
No, that's just an atrophic tubule. There were no granulomas in the infiltrate.
Okay. What about in this section here, Dr. Simlick?
Well, those are the larger cells are tubular epithelium. I mean, on a PAS stain, it highlight there's tubules that are contracting down and becoming atrophic.
Okay.
So yeah, acute interstitial nephritis with mixture of cell types, and I think we have another one even at higher power.
Okay, let me advance the slide.
Yep, you see it?
Not yet.
Give it a second. I think it's just the internet. You should be popping up.
Oh, there we go. So again, here we have an H&E stain. I can see a lot of hypercellularity, especially in this area around this tubule. Again, these cells, it doesn't appear to be just one predominant cell type. And then there are some areas here that don't have so much. So maybe in this area on this slide, it appears more focal.
Yeah, it's more dense there in the center, and the tubules are kind of getting chewed up. You know, there's active tubulitis. You could see cells within the tubular epithelium.
What about what's in the center of the tubule?
Would this be like a white cell cast?
Yeah. I mean that's slopped up tubular epithelium. You know, tubular necrosis. Yeah, and then over to the right, the interstitium's becoming progressively fibrotic. A lot of fibrosis setting in.
That's true. In this area.
Yeah, over there. Yeah.
Yeah.
Yep.
Hey, David, if this were lymphoma in the kidney, would you feel comfortable with this alone? Because all the different cell types saying that this is not lymphoma in the kidney because there's too many cell types?
Yeah, a lymphoma is a mononuclear infiltrate, so you just have a single cell type. But for thoroughness, I did show this to our hematopathologist. That's a pathologist specializing in lymphomas, leukemias, and they all concur that this is a reactive infiltrate. There's no evidence of lymphoma.
Thank you.
Yes, we could go on to the next slide.
Yeah, I'm trying to click it.
Here, I can advance it. Let me see. There we go. Can you see it?
I can see it on Shintev's computer.
All right, I'll give it a second.
Maybe I'll just move for a second. You can. Oh, no, I can see it on your. Okay, so this one here is a high power view with a PAS stain. Right in the center, you see a glomerulus. Bowman's capsule appears to be intact. Looking around, the capillary loops look opened. I don't see any hypercellularity within the glomerulus itself. Maybe some, I don't want to overrate it, that there's some mesangial expansion. I don't think so. But looking outside of the glomerulus, the tubules themselves, there appears to be possibly loss of the brush border. So some tubular atrophy.
Yeah, that one's acutely injured where the arrow is, loss of brush border, thinned epithelium. Those other ones are becoming atrophied with thickening basement membranes. And then the interstitium is fibrotic around the glomerulus. So I think it has a little bit of ischemic changes. The tuft is a little bit contracted down, from Bowman's capsule. Okay, good. Well, more of the same here.
Sorry, go ahead. Yeah, I can advance it now. So
Yeah.
there we go.
Yeah.
Do you see it?
Okay.
Not yet, not on either computer.
Okay.
Okay,
Yeah.
there we go.
There you go.
So again, we have a high power view of the glomerulus. This is H&E stain. Again,
PAS, right?
It's
Yeah.
my apologies, it's PAS stain. Maybe some areas of mesangial expansion here, but otherwise, this.
Yeah, kind of minimal. No diabetic KW nodules.
True.
Yeah.
And then again, the tubules appear injured, loss of blood brush border, and then again, and some areas of fibrosis in the interstitium.
Yep.
David, the chat asked about immunohistostaining for TB. Is that something you routinely do or only in such
For TB? Yeah, there's a stain, AFB, acid fat specialized stain, but we'd have to see presence of granulomas to stain for AFB. So I would say not indicated.
Roger, I think
Okay.
they were asking for staining for the T and B cells.
No.
For
Oh, sorry, my
Oh.
bad.
Yeah.
That's pretty funny.
Yeah.
Thanks, Bill.
Again, not indicated. I mean, it has no significance if they're T or B cells. If we had a suspicion of lymphoma, we do the stain, but otherwise not indicated.
I think I'm not indicated.
So you should see it pop up, Mel.
Yeah, so here we have a high power view of the Jones Silver stain, looking at the glomerulus. Okay, here, good. I don't see any spikes or holes in the capillary loops. Bowman's capsule appears intact. What is this? Anything significant?
Yeah,
Okay.
there's periglomerular fibrosis. I mean, as we saw, the interstitium's becoming progressively fibrotic. So I think there's kind of some ischemic changes to these glomeruli. Bowman's capsule looks thickened, and that's some periglomerular, fibrosis. So non-specific, injury to the interstitium surrounding the glomerulus.
Thank you.
I advanced it. Oop, there we go. Should be able to see it.
Yeah. Okay, so this is a PAS stain, high power view. Are these, I'm assuming are blood, like blood vessels are just, are they?
Yes, yeah, interlobular sized arteries.
Interlobular.
And
Okay.
do they look normal or narrowed?
They look narrowed, like, I don't know if the wall looks thickened.
Yeah, good. Yeah. That's called arterial sclerosis or fibrointimal thickening. Yeah, so going along with chronic hypertension. The one on the bottom there looks severely narrowed, more than 50% of the lumen is narrowed from chronic hypertensive changes.
Mhm.
Yep.
Immunofluorescence right here.
Yeah.
Okay, so this
Yeah,
is-
and completely negative for all immunoglobulins, kappa lambda light chains. Yep.
okay, I was about to ask what's ALL, but that's all. Okay.
Oh, yeah. Yeah, it's not a new stain we have.
I was like, oh man, another one. Okay, so here we have the electron microscopy view. Just to orient myself, this is the capillary wall. Inside we have the capillary lumen, and this is a urinary space. Looking along the GBM, I don't see any electron dense deposits all the way around, and the podocytes, at least here, oh, I should use my computer so you can see my cursor. The podocytes here appear intact, but then here maybe some loss. I'm not sure if that's just like artifact. just in the
Yeah, so it's
area.
actually detached there. It's kind of denuded, right where the cursor is.
Yeah, and you can.
But where you were over on the right side, yeah, they were intact. Maybe around 9 o'clock, there's some focal effacement over there.
Oh yeah,
right there. Yeah.
and you can see the nice fenestration of the endothelial cells, but otherwise, nothing else that I can comment on.
Next EM, you should be able to see that.
Yep, so here again in the center, that would be the urinary space. Okay, good. Here, capillary wall, urinary space here, podocytes appear normal. And then looking at the GBM, I don't see any electron dense deposits, and then that's just borderline normal size. And
Yeah.
it's the range is like 300 to 500.
Yep.
So for somebody that had 15 years of diabetes, not much evidence of it, huh?
Right.
Now, what's your diagnosis, your pathologic diagnosis?
Acute interstitial nephritis.
With some ATN
Oh yeah, with ATN.
Yep.
But wasn't there chronic disease there too, or no?
and some,
IFTA 40%.
yes. Steve, how do you put this together? Steve? Dr. Corbett?
Yeah, sorry.
How
I
do you
thought,
put- Your name is Steve, I thought.
no, I thought you said Dave for a minute. Sorry. Give me a second. Yeah, so what to do?
How do you put this together?
Well, I don't know how to tie the hypercalcemia into this, to be honest with you. I mean, David, I don't recall. Did you see did you see any eosinophils at all?
No, it
Oh.
was mostly lymphocytes, occasional plasma cells, and neutrophils.
Yeah, I mean, it's an acute interstitial nephritis. I don't know if it's related to the protonics or something else that you might have been taking that we're just not aware of. There's some chronic scarring as well, so this has probably been going on for a while. I honestly can't come up. I mean, there were no granulomas, and we know the 125 was normal, so it's kind of hard to put this in as a granulomatous process. I don't know how to tie it all together, to be honest with you. I think the acute renal failure is the interstitial nephritis. How to treat it? I mean, you stop whatever drugs you think might be contributing. and you put her on steroids, would be my first guess. But I honestly can't tie together the hypercalcemia. I mean, I don't know if the anemia is related to this or something else. I think she may need a bone marrow to evaluate it further to see if something else is going on. And there are two things going on and not just one.
So you'd give her steroids for presumed diagnosis of AIN,
Yeah.
and what dose?
How much did she weigh, Bill?
115 pounds.
So that puts her about 50 milligrams, milligram per kilo.
Okay. Before I hand this back to Bill, anybody else? Thoughts? Dick? Mario?
I think most likely, like Steve pointed out, the hypercalcemia is mediated by a cytokine, such as an osteoclast activating factor or something like it. I don't think that bone involvement has been ruled out, and I would do a bone marrow to study the changes in hemoglobin and what have you a bit further.
And that's really a good point. There's a lot going on, and the hematologic and calcium's been stressed over and over again. Does it explain the renal biopsy findings? I mean, maybe ATN from hypercalcemia, but I'm not sure it really explains the kidney biopsy. And I think that may be two independent or two separate things. I mean, it certainly needs further evaluation from a bone marrow.
Yeah, and she was transferred to Rush because of her previous lymphoma care was here. And so fortunately the hematologist came on board. But the whole presence of this monoclonal protein was bothering me quite a bit too, even though there wasn't anything on the Congo red that was positive. And so even though the immunofluorescence was negative and there was no light chain restriction, the fact that we did have a Fanconi's-like syndrome with interstitial nephritis, and we had an MGUS that was a lambda, made me at least want to be a little bit suspicious that there may be something on Pronase digestion, and maybe there would be some restrictions. So we actually sent off the tissue to Mayo, and lo and behold, it came back with lambda light chain restriction in a crystalline tubular pattern. And then we went back to the Congo red, which can often be seen on the Congo red and not the other stains. You can hopefully see my slide here. Right in the middle there was a crystalline structure in the interproximal tubule, and there weren't several, but there were enough there that it was very likely to be responsible for the proximal tubule Fanconi's, and then there is a resultant interstitial nephritis. Now, it's still possible the interstitial nephritis was protonics on top of it, but this was certainly screaming out that there was a lymphoproliferative process producing this lambda and infiltrating in the kidney. So then what we did is, since we had this, we were a little stronger in asking hematology to do the bone marrow biopsy, and they were going to do it anyway. And so it wasn't that much of a arm twisting situation. At least at Rush, everybody's pretty collegial. And they did it, and they found that there was the recurrence of the follicular lymphoma. About 10% of the marrow was involved. So this kind of brings up this whole idea again of pronase digestion, when to use it. We're always thinking about, and what is it? Pronase digestion was really created for a salvage technique. If you don't have any gloms on the immunofluorescence, you can do pronase digestion on the formalin-fixed paraffin-embedded tissue, and then you'll be able to get a relatively decent idea of what the immunofluorescence pattern would have been. And so that's why it was created. There's some reasons, though, to send for pronase digestion, since it's not part of the routine IF, even in the absence of not enough gloms on the IF. And I wanted to go through some of those. And so here's 5 basic indications for sending out for pronase digestion. 1, frozen tissue is not available. That part's easy, I think. The next are actual diseases where your immunofluorescence, there's 6. The 5 diseases. There's actual diseases where your pronase digestion can help unmask a disease that was hidden by the routine immunofluorescence, and there's hidden for different reasons. And so we can kind of go through some of those too. One is the first one is suspected light chain proximal tubulopathy or crystalline induced nephropathy, and that's exactly this case. We had a case where the crystallines formation from the lymphoma from the lambda was impairing the ability of the immunofluorescence to act appropriately, and with protease digestion, we uncovered it. The classic one that I think we're used to because MPGN is getting so much press is when you have MPGN with a monoclonal protein and you don't have light chain restriction, then we need to send that for immunofluorescence too. And that MPGN can be with negative staining or with C3GN and a monoclonal gammopathy. So both of these are, I mean, I know they're sort of different, but if I have an MPGN and I have an MGUS and there's no light chain restriction, that's an automatic send off for pronase digestion to see if there's actual restriction there. And then these last two are pretty rare. There's membranous nephropathy that actually has a pretty weak IgG and a fibrillary GN with an apparent monotypic immunoglobulin deposits by the immunofluorescence. And so this was our first case, or the first one that I was aware of, this proximal tubulopathy that was uncovered. And so here's why. The epitopes actually can get washed off during the tissue technique when you're doing the regular immunofluorescence, and because of that, they can kind of be washed away, and then you're not going to have enough of the antibody there that's present or sticking out, if you will, to bind to it. In the case of our crystalline case here, in the crystalline LCPT, that's light chain proximal tubulopathy, that's what our case was. And the crystals themselves impair the ability of the immunofluorescence to bind. And so that's one common cause of needing pronase digestion. And then lastly, we don't use this solution at Rush, but sometimes we get outside cases and they're transported in this, it's either Michael's or Michelle's. I'm not sure if David's still on, he knows how to pronounce that or not, but if it's transported in a different type of media, it's possible that, go ahead, David.
Yeah, it's Michelle's transport media.
Michelle's transport. And if it's transported in that, it might render your immunofluorescence to not be light chain restricted either. And so those are the three main categories I think about when do we send off for pronase digestion, and this is sort of why. So here's some of the cases where the membranous and A was negative by routine fluorescence or weak, and then they did pronase digestion and found that the kappa was there in a membranous pattern. And here's just several of the cases that have shown that where pronase digestion to the center of your screen unmasked the monoclonal kappa deposits. Here's some of the cases of the MPGN that we just talked about, where if you have MPGN and you have an MGUS and you're not sure if it's really an MGUS and an MGRS, you're going to need to do pronase digestion to see if it's really restricted. And then our case, which was sort of a little eye-opening for me, it was bothering me a little bit that we had this MGUS. I know we did not have Congo red positivity. It just, something was a little weird. And I thought, maybe we better just see if there's a restriction. And we found that there was restriction in this crystalline pattern. It's been pretty well documented. So this light chain PT or LCPT in a crystalline pattern often needs pronase digestion to the rescue. And so I think that's kind of the take-home point for here. We had interstitial nephritis, we had proximal tubular disease, we had a monoclonal gammopathy that didn't really fit. And ultimately, the bone marrow gave us the answer for treatment for this woman. And the bone marrow showed that not only was there a follicular lymphoma, but it was CD19 positive. And so they were able to clone, or they were able to find the clone and see that it's going to be responsive to Rituxan. So we've got several months, almost I don't want to give the exact details. We have several months follow-up. And ever since she's been back on Rituxan, her lambda completely disappeared. Her kappa lambda ratio normalized, so it went from low to normal. I also had treated her with steroids in case there was a component of protonics induced interstitial nephritis or something else. And we obviously stopped her protonics, and her creatinine was kind of hovering in the 2 ranges, and it's been there since. And so it hasn't really improved, but it certainly hasn't been exacerbated. And she's now once again in remission from a lymphoma standpoint, and in remission in terms of her monoclonal lambda.
So Bill, I have a few questions.
Sure.
You showed us the Congo red. Was that focally positive?
It wasn't positive for apple green birefringence.
Okay.
It was only positive because actually what they say on these proximal tubule Fanconis with the crystalline structures is that you can sometimes pick them up if you look really, really hard on the Congo red stain, that there's a slight color difference, and also that's the best stain to look at the crystalline structures. So that was one, and then that's another one. So it's not birefringence for apple green, but it's that the crystals are sort of highlighted on the Congo red. And when you know to look for them, you can scour and hopefully find something we did in this case.
All right. My second.
Yeah. The reason we're showing the Congo reds because they were focal. They weren't present actually on the H&E stains, just on the deeper section of the Congo red.
Great. My second question is, you guys didn't show the electron microscopy. Was that on purpose?
No, we couldn't find any of the crystalline structures on the EM, and they're so focal even on the entire biopsy that they're really hard to find on the EM. So what I just showed was this, which hopefully you can see this, Mario. This was from the paper of which shows that they are crystalline when they're able to evaluate them. So they have this crystalline lattice-like structure. This is what they look like on IF. But in our case, we weren't able to find them. I think they're so focal.
Yeah, the luck of the draw, especially with EM. It would have been nice if we could see that. There's such a pretty crystalline pattern, but it's kind of, they were pretty focal. It would have been pretty lucky.
My last question is, I thought she received obinutuzumab. Why did they circle back to Rituxan?
What they did is she had been doing so well on Rituxan, and then she fell off her maintenance because of her choice. So what they ended up doing is, because Rituxan was doing really well for her, is they actually desensitized her to Rituxan, and they went back to that, and it seems to be working. I think that they could have gone back with the obinutuzumab because that also had induced a remission, but I think they just chose. They found it was CD19 responsive, and I'm sure either one would have worked, but they decided to desensitize and put her on Rituxan again.
So this helps to explain the hypercalcemia as well, because the evidence did not favor a vitamin D related mechanism, but this is a lymphoma related mechanism, which is activation of osteoclast factors, which is independent of vitamin D. So the whole picture could easily be explained by the underlying lambda lymphoplasmacytic dyscrasia, if you will, tending towards a myeloma-like picture. Fascinating case, Bill. Thank you so much for sharing with us this very interesting and memorable information.
This reminds me of the what often happens in myeloma, where we think we've got we think we know what's going on, and the question is, what do you biopsy first? And if we do a bone marrow biopsy and you identify an obvious plasmacytoma or multiple myeloma criteria, they don't always need a biopsy. A kidney biopsy, that's for another time, somewhat disputable. But this is a little different. This is a lymphoma, and lymphomas, we think of these plasma cell dyscrasias typically with plasma cell dyscrasias, but clearly lymphomas can do it. And that's exactly what's going on here. And I can see how you went to the renal biopsy first, and it got you back to the lymphoma. It got you to a bone marrow, and certainly got us to some great pathology to look at, something we don't usually usually see. And it really required outside help to do the pronate staining to nail the diagnosis, because without that, you're left with interstitial nephritis. Now, maybe she would have got her bone marrow anyway, and eventually would have figured that out. But you're able to make the diagnosis, and it's really, these pictures here look, except for the EM, it looks exactly like the cast you had. And I think, astutely, we're so used to thinking this ratio as being high, but it's only going to be high with kappa. It's going to be low with a lambda. And, the clues are there. It's just, I don't think I put a lot together with this lymphoma. What's infinitely more common is that we've got a monoclonal gammopathy of unknown significance and another disease. But here's one, where if you see enough of these, they will go together. This is, as Dr. Glassick said, everything fits here. Anemia.
There were several of the cases here in these reports were myeloma, much more common than any other lymphoproliferative process, and also kappa was overwhelmingly the majority of the light chain that was produced. Lambda did have some, but it was minimal.
So did you do a bone survey at all, or did the hematology do bone survey to see whether there's evidence of lytic lesions? Because that's what you'd expect if this was OAF associated.
It's a great question, Steve. I'm sorry, I've got to get back to you on that one. I can't remember.
Yeah, I don't think lymphomas have to have clastic lesions to have lymphoma. That's the whole point. I think, I mean, we see it in myeloma, but I don't think lymphomas have to have holes in the bones.
Well, I mean, if it's osteoclastic activating factor, that's kind of the thought between myeloma as well. That's why I was wondering. I mean, the whole, I don't remember the alk phos being elevated, right?
It was normal.
Yeah, I mean, that's what you see in myeloma, and the whole issue of why the bone surveys are by the bone scans are negative is because technetium pyrophosphate's taken up by the osteoblast, and these are pure osteoclastic lesions. So the bone scan will be negative, and the survey, the skeletal survey, will be positive. But it's
The
just a
alk phos-
curiosity,
The alk phos is normal in myeloma, so
right?
not
Because
it's not elevated.
that's
Yeah,
indicative of osteoblastic activity.
That is a golden pearl, Steve, about the poor role of bone scan in the evaluation of these patients. The oncologists have replaced it with MRI now. And the pictures that they're able to obtain are classic. Now, what this case teaches us is something, I mean, there were hints that this was a dysproteinemic renal disorder, mainly globulins in the urine, a low anion gap, a reduced lambda kappa ratio, and it took an astute clinical nephrologist such as Bill to really take the additional step of a pronate study, because I personally was ready to just say, okay, another PPI-induced AIN, but kudos to you, Bill. This was great. Thank you.
Thanks.
So getting back to pronase digestion, we just had the board review course, and we had a question and answer session, and I asked Dr. Markowitz, Glenn Markowitz, you know, in your practice, where does pronase digestion come up? And yeah, they're exactly right there. Glenn said, you know, basically Bill's list. What I didn't, you know, think about at the time was this business of Michelle's solution, which is, I think, you know, Columbia gets a lot of outside cases, and I'm sure they're sent in some kind of preservative. And the hard part is really, when do you do pronase? You don't do it on everybody, but you don't do it on nobody. And basically, he said there's got to be, you know, if there's something funny about the case, either monoclonal gammopathy, then they'll do it. Unless it's clear cut without it, they'll do it. And if there's anything funny about the EMs, and I think we had a case like that where we had a fluffy infiltrate in the EMs that turned out to be a monoclonal immunoglobulin deposition disease. I think it was light chain deposition disease or heavy chain. I can't remember. I think it was Prevere's case, but you know, where there was something funny about it. So we're still kind of in this zone where not sure exactly when to order it. We don't want to order it on everybody, but we don't want to order it on nobody either. But it's been a real asset to our practice to be able to have it, and it's led to a couple diagnoses we wouldn't have otherwise made. Probably would have came to the same diagnosis here because the patient had hypercalcemia and got her bone marrow. But that's beside the point. Not to take away Bill's you know, glowing halo above him right now.
Exactly.
Wait a minute, I thought I said we needed to pursue a hematologic evaluation further because the hypercalcemia wasn't explained by
Right,
us.
Steve, you're right. You're the genius here. I'm sorry.
No, not me. You were the one that uncovered it, but we were on the, you know, we were on track. By the way, we quote this article all the time. Roger and I at least used to. You know, Agnes Fogel years ago had this article that she published in AJKD about the fact that we go witch hunting after paraprotein related renal diseases every time we see somebody that has a positive paraprotein. And my recollection was, I'm not exact, it's not perfect, but it's something like 50-50. Half the time they are associated with the paraprotein, half the time they're not. In retrospect, I wonder how many of those cases that were negative with pronase digestion might have actually been positive. And this becomes an example of that.
I feel like more and more we're learning about these monoclonal proteins, the more and more that an MGUS doesn't really exist. Now, of course, it still does, but I think it's a pathologic process a lot more common than we think. I learned a lot in this case. I always knew to send it if we had an MPGN. You know, I think that's just been beat over our heads. That's when you send pronase digestion. But this suspected light chain PT was a real eye-opening case for me. So I learned a lot too.
Yeah, and I mean, in all our years, I only remember 2 crystal-related paraproteinemic diseases. This one, and then when we had a crystal globulinemia a few years back, that was.
Yeah, there's a cryocrystal globulinemia, and then there's a crystalline-induced nephropathy, and they are different.
Yeah,
well, there's always
we had the other one formerly.
There's always cholesterol crystals as well.
There are. So, Bill, she did well.
She did very well. Yeah, her lymphoma's in remission again. Most importantly, her calcium's good. Her creatinine's hanging out at 2.
Had they
and-
stopped the Rituxan infusions?
No, they're going to now continue it, I believe, indefinitely.
No, had they stopped it before? They had stopped it and she was in
They had.
remission, right? Yeah, I think indefinite is probably a good idea, given that she's had 2 major events from this right now. Well, I'm going to wrap this up. Thanks, everybody. Great case, great discussion. Thanks, Mario. Thanks, Dick, for your input. The CME activity
Bill.
code.
Thanks, Bill, very much. Great case.
Thank you.
CME activity code is 486227. Keep an eye out for your email. Let us know if you want to get on the list, join our channel, and we should be back next week. If not, you'll get an email one way or the other. Thanks, everybody, and stay safe.